You know, this is awfully nice of you all to stay for this last presentation, and I think because you're being so nice and staying, that I'll make a deal with you. I'm going to talk about behavior change, but I will not change any of your behavior. Fair enough? All right. Really, really happy to be here. As Nancy said, I'm from Healthwise. Healthwise is a partner to ZeOmega. You might know us as a patient education company. We're a not-for-profit company that's been around 41 years with the mission to help people make better health decisions. Now, what our founder, Don Kemper, had the vision to do 41 years ago was to take the library of medicine, evidence-based medicine, and translate it for the consumer. It was a way of demystifying and equalizing that power differential that's been around for a long time in medicine as it's historically been practiced. Put the information in the hands of the consumers, let them take ownership of their health. So we've got a great mission and a great partnership with ZeOmega, and I'm really excited about talking with you about the work that we're doing to go further than content and really bring intelligence to content, if you will. Really bring science to content. See, we've got a great opportunity in this time of disruption in healthcare. It's a very uncertain time. It can be a little distressful. I'm a health psychologist. I spent the first part of my career working on the front line of care, and I can tell you, as many of you know, sitting in this room, there is a lot of distress for people that are on the front line of care. Lots of pain. So you all have the opportunity, and we would love to help you with this, you have the opportunity to bring something new to healthcare. And I think you're working towards doing that. But specifically, what I'd like to do is challenge us all to think about how we can bring behavioral science closer to the tool of our time, and that's the software, that's the technology that we're using, because I think that's where we can really break new ground. Now, why do I say that? Not just because I'm a behavioral scientist and I care about this stuff. I say that because I read the newspaper. 70% of our healthcare dollars are spent on behaviors, right? So we have a pretty significant crisis, and I'd like to focus on the crisis of prediabetes, but when I talk about behavioral science and prediabetes, know that behavioral science can help us with a lot of these behaviors that are driving health costs and health outcomes. So it could be smoking, it could be stress, it could be sleep, it could be adherence to medication or the non-adherence, it could be screening or not, it could be your ability to communicate your preferences to your provider. These are all behaviors that the consumer owns. And we have much room for improvement there. But let me focus on prediabetes, because that is a tsunami health threat to America today. 1 in 3 people have prediabetes today. 1 in 3 worldwide. And we have the opportunity to do something about that, but we have to be very intentional, and I'm going to propose to you that we actually have to be willing to change the model of what we do. So let's talk about that. Background on myself, why do I care so much about behavior change? I mentioned I'm a health psychologist. I was on the University of Washington faculty for many years. I trained hundreds of family physicians and allied health professionals and nurses and social workers, wonderful people all, and they saw these behavioral issues all the time. Patient comes in with a chronic cough, right? And they need some medicine to sleep. What's the real issue? The real issue is that they're a smoker. But Band-Aid on, here's your cough medicine, we'll see you next time. Another patient comes in, a diabetic with an A1C, 9, 10, really beginning to get into that danger zone in terms of the long-term consequences of uncontrolled diabetes, where you lose a limb or you lose your eyesight. And that patient, obese, has tried 7 times to lose weight and hasn't been successful. So what does the doctor do? Adjust the insulin dose. Or the patient who has high blood pressure and the doctor prescribes some medicine to control that, the patient doesn't want to take it because of the sexual side effects and doesn't feel like he can mention that to the doctor. These people that I trained that taught me so much, that I have such deep respect for, couldn't get to those issues. It was Band-Aid, 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 Band-Aid. Now, why couldn't they get to it? They're good people. They're doing great work. They couldn't get to it for two reasons. Number one, they didn't have the time. And number two, they didn't have the training. For me, being responsible for the behavioral science curriculum, I got the equivalent in a 3-year residency of 2 weeks of their time. Obstetrics got 6 months. Now, I'm not making a judgment statement. What I'm doing is I'm giving you all an opportunity to think about how big the opportunity is for disruption in your space, because it's not going to happen from the docs. And quite frankly, I think we want to let the docs be the docs. I think we want to let them do what they do so well, but we need another type of workforce to deal with these behavioral issues. So that's the first part of my story about why I feel passionately about behavioral science, but the second is much more personal. So these are my twin daughters, Sophie on the left and Lily on the right. They are 10 at the time, and they are starting, just having started 3rd grade. When I was diagnosed with stage 2B breast cancer. Now, when you are a relatively young woman and you have young children, they throw the book at you, as they say. So I got chemotherapy, I got mastectomy, and I got radiation. As you can imagine, for little 10-year-olds, they don't know what to do with that. They didn't know what to make of it. They were just scared. But they talked with a friend whose dad had gone through cancer treatment the year before. And he said, you know, or the friend who is a lady said, a little girl said, you know, you got to have that hair party. Well, one of my daughters comes home and tells me the story. I'm like, the hair party? Yeah, when your mom's hair starts to fall out, and have her let you cut it. So we had the hair party. This tells you a lot about my daughter's personalities. Lily's like, bring it! And Sophie's, scared. They have their own ways of coping. And because I'm a woman, it was not just a cut, it was a cut and a color. So we let them get out their silly string and do all kinds of fun things to it. Steve made the point this morning, so I'm just making it again because it's so important that we all remember that at some point in our lives, ourselves and the people we love will be ill. Now, you framed it in terms of selfishness, and I think that's a fair way to frame it. I frame it in terms of vulnerability. That when you are ill, you know vulnerability like at no other time in your life. And these are the people that we're caring for. So what kind of relationship do you want to have with these vulnerable people who one day, if not already, will be you, your spouse, your child, your father? You're innovators. It's an overused word, but dang it, you are. And the reason you are is, again, as I'm trying to walk you through this story, I want you to see that we're taking a medical model and we're trying to apply it to a behavioral problem. And I think we're not going to be satisfied with the outcomes. So you all have the opportunity to take a behavioral model, behavior science, and put it front and center into the programs that you sponsor, that you train for, the applications that you use, etc. And you have a wonderful partner in ZeOmega, and I think all of us can go further. All of us can innovate in this space further, and I'd say we need to do it faster. So I'm going to bookend my talk by referencing a few innovations that have come before ours. Screws, or the screw press. George Selden, who was actually the one to first patent the automobile in the United States. And the third one is, of course, software. So why focusing on behavior? For the first time in human history, preventable chronic disease is killing more people than infectious disease. For the first time in human history, Our problem is not polio. Our problem is prediabetes, right? Our problem is not smallpox. Our problem is stress. So I feel so passionately about the role of the care coordinators and the role of the coaches and the nurses and the platforms they all use to help us pivot from the medical model, which is assess, diagnose, treat. We want that. You have multiple sclerosis, you have cancer. I had cancer. I've been treated and I've trained doctors, and I am so grateful for that. But that solution only works for those kind of problems. The solution of our time, this tsunami of behavioral issues, needs a different type of science. This has been talked about all day, the triple aim, Don Berwick's call to action, the target we're all trying to hit, better experiences, better health, lower costs. It's good that we have a target. Now my question for all of us is, what's our strategy? And I'd encourage you as a first step, if you buy into the idea that the problem of our era is a behavioral one, if you buy into the fact that behavior change science can help us, and if you buy into the fact that software, the applications that we're using, can accelerate that even further and can scale it even wider, then I'm going to ask you to look at hitting this aim, the triple aim, through the lens of your patients as partners. Okay? And partnering with patients instead of managing them. So managing, it's kind of been usual care, and I mean no disrespect when I talk about this, but it's kind of block and tackle. Somebody's got a request to have a back surgery, they've got a herniated disc, they're having a lot of pain, someone has to take the call, check the symptoms, get the pre-auth, we'll block some of them, and they won't get the surgery, and others will get through. And that's kind of usual care today. And it's not a bad thing. It's kind of built off of a financial model and a little less built off of a partnership model. But to get to the triple aim, you could start in this partnership model by really going after what is the experience. Nandini mentioned this morning about trust, and I want to say it's always the best place to start. So you have somebody on the phone, and they want back surgery. In a partnership model where you're building trust, the first thing you do is you say, you must be in a lot of pain, right? It's empathy. It's not, what has your doctor said about this, and have you been to, and have I seen, nobody in this room would do that, but you know what happens. It's you are wanting to do this drastic thing and take this risk of back surgery because you are in so much pain. Tell me about it. Number one, empathy. Number two, people come to us with their own life experiences. Ask them about that. What have you tried? What's worked? What hasn't worked? And you could offer them, you could say, oh gosh, you've tried a lot of things, and you've done over-the-counter meds, and you've done some physical therapy. Would you like to go through a shared decision-making tool together to see what really would be the right choice for you? And your care coordinators could do that. And what you'll find is if we insert that partnership step about making a shared going through a shared decision-making process, what you'll find is that people, when they hear about the actual risks of surgery, and they hear that in 5 years, whether you have surgery for herniated disc or you don't, the outcomes are equivalent. Some of your patients going through that process will say, yeah, maybe I don't want to do that surgery. And you can support them in that partnership model through, well, let's get you some PT, let me stay in touch with you, etc. Well, now we're getting to health outcomes. We're having fewer surgeries, so we're getting to cost, but not through blocking and tackling. And that's kind of step one in behavior change. So this is being recognized in the industry, this being patient engagement, a new role for the patient. So they've now done a second issue on this, Health Affairs. This was from about 1.5 years ago, where they called patient engagement the blockbuster drug of the 21st century. So thank you, penicillin, seriously. 200 million lives saved worldwide from penicillin. That's a great thing. Guess how many people have diabetes? I'm not even counting about pre-diabetes, the precursor. 422 million people. So the blockbuster drug, get people engaged in owning their health and get them towards experiences that'll help them be successful in changing their behavior. Now let's talk turkey for a second. Some of you might be feeling skeptical in this room, like, is change even possible? And I don't blame you for that. I have those doubts myself. Like, I think my father, he was a 2-pack-a-day Marlboro man, and I got him when I was probably 7 years old. I bought him a pipe because somebody had told me, well, if you get him smoking a pipe, it won't be as bad for his heart and his lungs as smoking cigarettes. See, I was a little behavior change advocate way back when. But of course it didn't work. He didn't quit until he ended up in an ICU, St. David's, at the age of 45 with a heart attack. And then my teenagers, my girls are 15 now. I'm 6 years post-cancer diagnosis, doing great, strong. I can handle these 2 teenage girls. But I wonder, will they ever change their behavior? My daughter Lily, it's like she's living on an island inside her room, and the island is all of the clothing that hasn't been washed. It's kind of gross, right? And it smells, but I can't get her to change her behavior. So what I would suggest to you is we all have our stories that might make us skeptical that behavior change is possible. And that's a thinking error. We all make it. We all take an individual experience and we overgeneralize it. That's the way human beings think. So let's take our thinking errors and let's put them against some hardcore science. Let's put it against the CDC. They're pretty credible people. They have been running a program now to address prediabetes. They've been running it for 15 years, if not longer at this point. These data are 2 years old now. And for people who had prediabetes, they gave them 2 options. Number 1 was to take a pill, take metformin, glucophage, also used to reduce the production of insulin. And they could take that and see what it did to their prediabetes. So trying to arrest that 15 to 30% that'll become full diabetics. And now you have an irreversible chronic illness. So there's a metformin group, and then there's an intensive lifestyle group. These are the 15-year outcomes. This is not bad. 1 in 3 people, just by taking a pill every day, reduced their risk and did not develop type 2 diabetes. But this next one is the one that makes me put down my story about my dad and my daughter. Lifestyle change, 58, over half of the people reduced their risk of developing type 2 diabetes. Behavior change is possible. It just doesn't happen by accident. So what do we need? Well, what they did in the DPP program, it started out with a very intentional collaboration with the YMCA, and they had 3 core components. Number 1 was a curriculum, teaching people about carb counting and exercise, etc. The second thing was they had an assigned coach, and that coach was their behavior change facilitator. And the third thing they had was a support group, other people who are working on the same changes. So it's possible, but it's not easy, and we're not going to get there by accident. Okay, we have an epidemic, and it is behavior. We have some evidence that behavior change science works. So now what? Now you all want to know, all right, how do we change people's behavior? We don't. We don't own the lever. We don't pry people. So I want to invite us to shift the paradigm a little bit, going back to that concept of partnership. In the medical model, there is an expert, a doctor, and there is a subject, a patient. And by the way, I'm not doctor bashing. I married one of you guys. I married a family doc, and he's a lovely person. It's just a different way of thinking, right? In the partnership model, which is the behavior change model, we are not there to do anything more or less than be facilitators. And so how does behavior change science actually work? Well, it starts by building that trusted relationship, by acknowledging that people want to be as healthy as possible. There is no more precious resource we have, none, than our health. Get cancer, sit at home, have no hair, and check me if you disagree. So even though we might look at someone and we might say, by the way he looks or the way she looks or the things they're smoking or the things they're eating, we might think, oh, they don't want to change their behavior. You're wrong. Everyone's motivated to do something. We just haven't been very good about eliciting that motivation. And we can get better with training. So what do we want to train on? The most effective intervention that's known today is motivational interviewing. And Miller and Rolnick, who are in the 4th edition, I believe now, of their work, call this a collaborative conversation style that supports an increase in change talk. That's the active ingredient of motivational interviewing. And it's used to strengthen a person's own motivation and commitment to change. So I want to say a little something about incentives here, because that's extrinsic motivation. And what I'm talking about here is facilitating intrinsic motivation. There's a lot of stuff going out there. As a scientist, sometimes it makes me cringe, but you know, I understand capitalism and I understand we have to experiment, but there is a sound amount of research that tells us extrinsic, i.e. incentive rewards, work, but only for simple behaviors. Get a flu shot. Have a screening test. When it comes to complex behaviors, behaviors that we have to own, right, and manage over success and failure over the long term, it's all about intrinsic motivation. And MI is the best thing out there for harnessing that. Let's do a little thought experiment, and you can try this on your own. I want you to imagine a health behavior you would like to change. And we're going to do 2 rounds of this little thought experiment. And nobody has to share, but it's a health behavior that's important to you and you have control over, right? It can't be, I have a genetic thing and I don't want to have it, right? That's something greater than, it's beyond our control. So I want you to think about what this behavior is, what this health behavior is. I want to drink less caffeine or less alcohol. I want to sleep better. I want to exercise more. I want to eat more fruits and vegetables. I want to meditate. Whatever it is, I want you to bring it to mind. And think about it. And in round 1, I will be your coach. You know that if you don't change this behavior, bad things are going to happen. You know that people who don't sleep more and who look at their devices before they go to bed, that they end up with an increased risk for a heart attack. You know that by not eating those fruits and vegetables, that you're increasing your risk of cancer. Now, you're doing all of these things. They're really putting you at risk. And I'm going to tell you what to do to mitigate that risk, okay? So pay close attention. I want you to take your running shoes and I want you to put them next to your briefcase, so every day in the morning you'll have a cue in your environment that will remind you that you should go run. I want you to set an alarm on your phone that will be your little bell of mindfulness to tell you it's time to meditate. I would like for you to go and get your A1C screenings so that you can see how well your body, and particularly your pancreas, is able to manage your BMI. I want you to wear your seatbelt. When is the last time that you had your flu shot? How many hours of exercise have you had this week? Okay, think for a second what that experience is like. Reflect on it. What did it feel like? What reactions did you have? Round 2, same thing you're working on. I'm super parched today. It must be this dry Texas heat. Okay, round 2. I'm also your coach again. I want you to tell me something that's been going well for you the past few weeks. That's great. I'm curious, did you have some role in that? So you're really making an effort. Congratulations. Now, you've said you want to work on something today, and I'm very curious. Tell me why you chose that and not something else. Oh, you have an anniversary coming up and you'd like to look nice. Oh, you want to be a good role model for your kid. Interesting. What else? Why is this important to you? Now, one more thing, if you don't mind. I'd like for you to imagine your life 6 months from now, and you haven't made this change that you're thinking about making. What do you see? What do you feel? What do you think? And one more, let's imagine 6 months from now you have made this change. What are you doing? How are you feeling? What's that like? Thank you for participating. Now, of course, maybe nobody did, but that's your choice. I'm not here to tell you what to do. I can't change your behavior. I can only facilitate it. But what I would describe the first round of the thought experiment about is standard prescriptive care. And we're in danger in the care management field, care management, care coordination, coaching, all of these things that we all do and we all care about. We're in danger of taking that from the medical model and inserting that into our work today. And I'd ask you, if you went through the thought experiment, what did it feel like to be on the receiving end of that? Now, the second round of the thought experiment is evocation. That's what motivational interviewing is about, because it realizes, through lots of research, that the most important conversation is the one between your own 2 ears. Not what I say. In fact, the more I tell you to do things, the more you're going to resist. Sometimes when I'm in talks, I tell people that they have to get up and give me 20, jumping jacks. But sadly, they do, and then I feel sort of guilty because, I've got the mic and the power, and I don't want to do that. But you see what I'm saying? You have an opportunity to bring a new model to the work, but we have to be intentional about that. So the conversation between a person's 2 ears, what we're really trying to mine is the active ingredient of motivational interviewing, is this change talk, where someone talks themselves into change. I have to stop smoking to set a good example for my kids. Now, you're living with that voice 24/7. You can tune me out pretty quickly. I'm going away. And what stops change is what they call sustained talk. And those are all those reasons to keep on doing what you're doing. I've tried to quit before, and I always relapse. So in the motivational interviewing work, we are facilitating trying to get the change talk louder than the sustained talk. And when we're good at doing that, it works. It works. Over 200 randomized control trials and 4 meta-analyses showing that motivational interviewing is more effective than anything else we could do to support behavior change. Now, I'm going to go ahead and tell you a couple of things that I notice as being barriers to this work, because a lot of people are trying to bring motivational interviewing to their work. I get to, as a consultant, go and see, watch health coaches, talk with people about their program design to bring best practices of behavior change to that. And there's 2 cautionary tales I would tell you. The first is that I'm seeing a lot of, and again, no disrespect or judgment here. Hopefully it's just an awareness building exercise. But the first thing that I'm seeing is one and done training on MI. Oh yeah, when everybody comes on, we onboard them, they get their MI thing, they get 3-4 hours. That's not going to build proficiency. In fact, even if you do booster shots like a year later, what builds proficiency is having someone listen to your work using a standardized coding tool like the Mighty, getting feedback and coaching. Practice, right? Practice. So that's a cautionary tale that if you're working with MI, the first thing I say is congratulations, you're bringing in a best practice, that's terrific, but don't think the work will be delivering on its promise in terms of these outcomes without the opportunity for the coaches to actually practice and develop their skills. The second barrier that I'm seeing in my consulting work is channel conflict between the application that the coach is working in and the MI intention. And I was speaking with the chief medical officer here of ZeOmega about this, that you all are aware of that. This is a big, hairy challenge, which is why I want to wrap my arms around it. How do we take an application that's all about coding, so we have to get discrete values, zeros and ones and yeses and nos. How do we take that and have it be in alignment, in harmony with MI? MI is all about open-ended questions and affirmations. And I think it's too much to expect the coaches to figure that out on their own. What a great opportunity. It's a great problem for us to all solve. So the second part of behavior change science is delivering tailored interventions. You make that partnership in the MI, and what does a tailored intervention look like? Well, the first thing is you need a framework. I'd be really curious to talk with any and all of you to know who is using a behavior change framework, being uber intentional about putting this into your interventions. We use one called, it was developed out of Cardiff University. It's called the Sustainable Change Logic Model. The reason we use it is because it's a meta model. They wanted to lift above all the proprietary stuff. I got my Prochaska, HRA. I've got my social cognitive theory thing. I've got my Kate Lorig and Stanford's self-management program. All good stuff, all good science. But they wanted to, in an agnostic way, lift the evidence up above that. And so they looked at over 3,200 publications, first one from 1941, and they found out that people have 5 fundamental needs when it comes to behavior change. These are the needs: awareness, learning, motivation, behavior, and sustainability. So awareness is what we think of as knowledge. What is prediabetes? Why should I care about it today? Why don't I wait until I have a chronic condition? How does my behavior affect my long-term health outcomes? Learning, think of that as building skills. Now these two, awareness and learning, have been the bread and butter of patient education, and I think of care coordination. But if there were enough, 18% of Americans wouldn't still smoke, because I think it is not a mystery that it's bad for your health. So this framework tells us, yes, education is necessary but insufficient, skills very important but also insufficient. We need to address these other stages: building confidence and importance in motivation. Behavior, that's building a personal action plan. I commit to do this in the next week or two. And sustainability, I lovingly call the February 8th syndrome. And this was inspired by something I heard on the radio on February 8th. In case you didn't know this, fun fact, that is the day that gym attendance precipitously drops after January 1st, never to regain its levels that it was between the 1st of January to the 7th of February. So going from behavior to sustainability is going from an action, which we all love to start things, me included, and making it a habit. And it's not easy to do. So now we think about the populations we're taking care of, and we don't just think about them as diabetics or CHF patients. We think of them as individuals on a self-management behavior change journey, and we can get much more personalized and figure out where they are in that journey. And this is where it gets brilliant to me, because there are a lot of folks out there doing work on segmentation and staging. If I were to ask you, how many of you capture some kind of a readiness ruler or this or that, I bet a lot of people would raise their hands. But this is where the magic happens, because we don't just say where someone is. In this review of these 3,200 and so many studies, they mapped which interventions were most successful for people in which stage. We have so many behavior change interventions out there. We've got short-term goals and long-term goals and rewards and social support and problem-solving barriers and all of these things. And I think for the most part, we're kind of throwing them out willy-nilly. We don't have to do that anymore. We have a framework, we have a model that says if somebody's got that February 8th syndrome, it's a great time to talk with them about tracking. It's a great time to talk with them about barriers. So the intervention is now attached to the stage. Okay, now we gotta play, because you guys have been awesome, and I'm gonna illustrate this point because I'm going to teach you all how to fly fish. I'm from Idaho, we like to fly fish, but it requires a little bit of audience participation, so how fun is it when somebody at a meeting says, grab your cell phone? So grab your cell phone, we're gonna do a live poll, and I will show you how we're taking this science in a fun way at first, how we're taking the science and embedding it into what we do at Healthwise. Okay, so start a new message. Everybody got their cell phone? Raise them up so I can see them. Audience participation is awesome today. Thank you so much. So in the to field, you're gonna put 22333. Don't fill out the message yet. I'll show you that in a second. Alex is gonna help me. So 22333. Now, you're gonna put in that message field a 6-digit number, but you don't see it yet. So, Alex, if you don't mind popping us out, I'm gonna show you one of the questions that we're using in our 6-item listening tool to figure out where someone is in the behavior change journey. And so this is a question about motivation. With everything going on in your life right now, what priority does fly fishing take? If it's very high, 29832. If it's somewhat high, 29875. Medium, 29880. Somewhat low, 32247. And very low, 34217. So this is kind of like a little horse race. Oh, it's full. Okay, if you haven't gotten in yet. All right, so this is, I forgot I capped at 25. My apologies, and thank you everybody for playing along, but this makes my point. So we've got 92, let's round up to say 96% of the participating audience is not interested in fly fishing. So let's go ahead and close that, Alex, and I'm gonna go back for a second and show you this is a common mistake that we make in coaching. I'm gonna teach you how to fly fish. I'm gonna teach you how to tie a knot and make your own flies. I'm gonna teach you how to do your casting. I'm gonna teach you how to, do you see what I'm saying? It's that we're making the assumption that the skill training we're doing is relevant and important to the target audience. It's a very flawed assumption, especially with you guys. This is the lowest number I have ever gotten in my fly fishing survey, so I thought it would have been a little bigger in Texas. So where you would have fallen, so we use this Cardiff model. We've put it actually, we've engineered all of this, and we have a brief, again, I call it a listening tool. You might call it an assessment. I'll show you that in a second, to place people into these 1 of 5 stages. And in this instance, sure enough, you are not super motivated to fly fish, but it's good to know that. So instead of getting into skills training, what I'm gonna do is I'm going to, we've got metadata that takes the behavior change stage and the subject, and will give you a much more tailored intervention. So for you guys, I've got some content. Fly fishing, is it right for you? Fly fishing, getting support to get out in the water. Fly fishing, a great excuse to get away from all those annoying people. Trying to get a little bit more relevant in our tailored content interventions. And we get to this personalized experience. So Maria says, well, I don't have to worry about heart disease. What do I have to worry about? I've got to worry about my grandkids and my kids and my job and all of that stuff. So she's in that stage we call awareness. And she can get a very tailored video. I'll show you an example.
Think of the women you know. They run at full speed morning to night, taking care of kids, working, running errands, making meals. They're too busy taking care of other people to pay attention to themselves or worry about having heart disease. But all women, and that means you too, need to pay attention to their hearts because heart disease is a leading cause.
So I just cut that short for time, but you see, that's really someone who didn't even know that she should be worried about it. And versus this gentleman, Paul, and he knows he's got a family history, and he just can't prioritize it. He can't really figure out how to get this front of mind given everything else going on in his life. He's in the motivation stage. So here's a video he could see.
I'm the same age now as my dad was when he died. I learned a lot from him, including how important family is. One thing he taught me was to learn from other people's mistakes. So when I was diagnosed with high blood pressure, I started taking the medicine. It's one thing I can do to help me live a healthier life. I try to eat healthy and work out regularly too. I'm not always perfect. I slip up sometimes. But then I think about how my dad would want me to do better. And I think about the example I'm setting for my kids. I'm grateful to my dad because he motivated me to take care of myself, for me and my family.
Okay. So you see, and again, what we're doing at Healthwise is as we build our entire video library, and now with our newer written content, we're taking the behavior change techniques and we're embedding them into the content. So the metadata will go grab the one that's right for what the person has told us they want and serve up that intervention that can guide them to success experience. So let me wrap up with the 3 stories. Told you all you're innovators, so I want to talk about these innovation stories. And I would like to talk about them through the lens of Simon Sinek. Simon Sinek had a TED Talk where he talked about innovation and leadership that has been viewed 27 million times. I only watched it 6, but still a lot of people have watched it. And he said that one of the things that we can spend more time and intention around is talking about the center of the circle. That's the why. When in fact we spend too much time talking about the what or the how. What is this? Oh, look, it's a skinny pen, and how do I use it? I click this and I write notes. That's interesting, but not compelling. We want to be compelling. So we go to the why. Why? Because I'm at this awesome ZeOmega user conference, and I've heard so many inspirational things. I need to capture them so I can bring them back to my home organization. So I'd like to look through these innovations through that golden circle exercise, if you will. And the first is the screw press. This is the earliest machine in human history. And it was invented in the 1st century after death by the Romans. So what is it? It's a screw press. How does it work? Well, it creates pressure by turning something through a threaded shaft. What? How? Interesting. Why? Torture? Well, no, it was a little nicer than that. First, they used it to crush grapes and make wine. That's a pretty good why. The second reason they used it is it was used to print the Gutenberg Bible. So that was the introduction of the era of printing, a big thing in human history to communicate ideas beyond one-on-one. Pretty big why. George Selden, he is an American, a New Yorker, born in 1846, and he is the one who he submitted and received the first patent for his road engine, which is essentially an automobile. So what is it? It's an automobile. How does it work? It's got a combustible engine. Why did we need it? Because we could go further on the machine than the horses could take us. That's pretty cool. So, and the third I want to talk about is software and the healthcare evolution or devolution. So to devolve something is to take it out of the hands of power and put it to the masses. That's the total promise of health information technology. So we have health information technology. It's become very commonplace. It allows, what is it? It's software. It allows different systems, and in the case of healthcare, different roles to communicate information, be they the payer or the provider or the patient, et cetera. Why do we have it? I heard a lot of people talk about the why of software today. Very compelling reasons. And one of them is as a data aggregator, right? To aggregate data gives us patterns and develops insights. I'll go show you an example of that. This is CDC data on the BMI rates. You'll see white, they don't have data. If it's light blue, these are BMIs over 26 or 26 and over. Light blue or medium blue, not a big deal. This is 1990, 2007, 2010. Check out the burgundy. This is a data aggregating pattern showing us the obesity crisis in our country today. That's a cool why. I like that why. But I would summarize to you to say we've got another why or another purpose. And that's to use software to be a behavior science distribution engine. That's the devolution of it. You don't have to go and get a professional coach. You could have your care coordinator and your nurse and your health coach that are actually delivering on this science, but it has to be embedded in the software. I think ZeOmega is a great partner and has a great start. What they're doing, Nandini talk about the 5 pillars of health, and in particular talking about holistic patient-centered care management. That's what I'm talking about. And personalized cares for care plans for truly patient-centered care. That's the direction they're going in. That's the direction you're going in. Let's be bolder. Let's be bolder. I couldn't think of a group to do that more effectively with than ZeOmega, and really pleased and honored to have you all give me your attention so late in the day.